So welcome everybody to another orthopod from Ortho Evidence, and we are in conversation with Professor Francesco Benazzo, who is currently serving as chairman of orthopedics and traumatology in Pavia, Italy. Francesco, thank you so much for joining us today.
Thank you for inviting me to share with you my experience with this such a strange period of our orthopedic life, because it was really unthinkable just 1 month and a half ago that we could be in this situation in our hospitals. Just to be precise, I moved 1 month ago from the hospital of San Matteo in Pavia to another hospital in Brescia. And maybe you know that Brescia is one of the epicenter of the COVID virus.
Absolutely,
I kept my university position in the same University of Pavia, but my clinical practice should have been done in this hospital. And it worked quite well for the very first week. And then we went progressively to a lockdown of our any surgical activity, because we in the first phase we slowed down the elective surgery. This is a place where I'm performing almost 30 joint replacement per week. And then from one day to the other, to a complete shutdown of the surgery, because everything was completely devoted to the treatment of the COVID virus. And this is something, the very first things I want to say, that we were not prepared to this. We were not prepared psychologically more than from the organization point of view, because this hospital turned completely in a couple of weeks to a COVID hospital with more than 400 beds completely devoted to that, 71 intensive care units bed for the COVID virus. And but psychologically, being an orthopedic surgeon more than a traumatology surgeon, you have to completely change your mind from one day to the other and ask yourself, is it true that I'm leaving this situation, which is completely out of our mind? I think worldwide would be the same in the most affected areas here in Europe, as well as I heard in the United States as well. So the way of our living habits has completely changed. That's the reason why I got a lot of time nowadays during the past 2 weeks to finish all my a lot of papers that they were on the way to the end.
We're reading and reading and reading.
5 papers to 5 different journals on knee prosthetic replacement, and that's the only positive note that I can bring to you. From the practical standpoint, the hospital has reacted quite positively and very early to this tragedy, because the willingness of the doctors and the nurses in this place, especially in Bergamo, the other most affected town in nearby, the willingness of the doctors and the nurses to help and assist this patient has been incredible. As a matter of fact, we have already reached almost 82 death casualties among the doctors in Italy. When I wrote with Alistair Hart from UK a letter to the editor to Lancet, there was 2 weeks and a half ago, the doctors who lost their lives were only 14. So we had an incredible amount of increased number of casualties among doctors and nurses as well. From the generally speaking, probably you know that we have a healthcare system which is socialized, as in Canada, but it's different from region to region. In Lombardia, the administration has defined 3 hubs for trauma, 3 main hubs, and the other hospital became spokes to these hubs. Even big hospital, even big trauma centers. And so that was a central decision to transform previous hubs hubs for COVID or special diseases. In my hospital, we became a hub for cardiovascular disease during this period and COVID virus patient. And then we have progressively been locked down in our houses. It was not a sudden decision because starting March 7, we start to not being able to assemble. The traveling has been a little bit controlled. After 1 week, everything was shut down, restaurant, everything. And this has caused a decrease and a sudden decrease of the traumas. This is another point to be taken into account because the social distances we must keep and the strong limitation of traveling has caused a positive dramatic decrease of the polytraumas. We have only fractures of the elderly patients, most of them, wrist fracture, and most of these elderly patients are positive to COVID. So that has created a new way of organization of the surgical OR and all the surgical activities we have in our hospitals, with a lot of information needed to be gathered and traduced in practice from 1 hour to the other. Because just think of the protection and the personal protection for the surgeons and nurses, together with a lot of news coming on the time of the virus can stay on stainless steel, plastic. You are publishing on JBJS a nice paper on that.
Oh,
I read that paper yesterday. And the time the virus can survive on the surfaces is important. The load of the virus and the charge of the virus over there is still important. But the news, they were not clear in the beginning. So the amount of precautions to be taken has been guessed more than known perfectly and exactly.
Right.
So this is the reason why we had a huge exchange of information, maybe not so clear, maybe not so true, worldwide among the surgeons. What do you do in your practice? How can you organize your surgical OR? How can you be safe in treating this patient? Do you test all this patient before surgery? You wait for the result for the test or not? And sometimes it's not possible. Most of these patients, and this is an experience of yesterday, news from yesterday from my old hospital, where I still am responsible for the residency program. All the fractures arrived yesterday, femoral fractures of the elderly people arrived yesterday. All these patients were positive for a viral pulmonitis, even with a negative test. So the consequence for that is from now on, from a couple of weeks ago, now and on, we must treat all these fractured patients as positive ones, with the consequence that we cannot keep them in a double room. Maybe it would be better to keep them in a single room, and that will cut by twice, by the half, the reception of the hospital, the capability of the hospital to accept a patient in that way. That's true that it's positive that we have a decreased number of traumas. I have collected data from different trauma centers in Italy, because I'm a member of a trauma society as well. And we have collected the incidence and numbers and quality of trauma starting from February 21st. That's the day where we had the first Italian affected patient, up to the March 31st. And we are comparing the incidence of this trauma to exactly the same period of the last year. And it's very much interesting because, again, polytrauma has almost disappeared. We have only domestic trauma and fall for the all patients. And most of them are affected because they come from hospice, many of them. By the way, in Bergamo, the nearby town, so far we got almost 700 casualties among the guests of these hospices on a total number of 6,000. So more than 10% already already died. This is considering that this locking down of our social lives will last for a long time, because even if we start the so-called, as the politician calls, phase 2 of a progressive liberalization of our freedom of motion, movement, and so on, we will not be free, completely free of moving until the end of this year. That's my perspective. But that means that the trauma will stay lower in number for a lot of months, and that is important to be taken into account, because in a situation of socialization of the healthcare, the administration should think of changing the rules of the game, reallocating more resources on elective surgery, and less on trauma surgeons and trauma centers. Why this? I'm afraid, being a joint arthroplasty surgeon nowadays, that the resources to keep this kind of surgery feasible in the near future will not be sufficient, because a huge amount of money has been diverted to save the lives of the patients. And so if we keep the same firepower for the trauma, this is not good, because we will have the need of more elective surgeries. In these 2 months, all the patient needing a surgery, not urgent, but needed for the quality of the life, joint arthroplasty, rejoint, has been reallocated for when, nobody knows. So we are doing a big effort to reorganize our surgical theater, our pathway for the patient. We will start to operate again on April 20, but only 3 days a week, morning to evening, and we expect to be able to perform only 3 big cases per day, because the changing time between one surgery and the other, one patient to the other, will last 2 hours, because whenever we change the surgical theater, which is a possibility, but we need more nurses, or staying in the same theater, the recommendation are to wake up the patient inside the same surgical theater, to bring that back to the room without any stop in a recovery room, because the recovery room with other patients could create an aerosol inside where. So the rules of our surgery will change. And so we are in a moment where we have fortunately, some clear ideas on how to avoid the virus, should we treat the patient, but still the future of our surgery is quite uncertain for the moment. We are really doing our best job to reorganize ourselves for the benefit of the patients.
I mean, I can't thank you enough for that summary, because I mean, it really covers everything. And the one thing I've heard you say a few times already is we need data. And it looks like you're on the forefront of collecting that information so you can decide and make good decisions, because it seems that by demonstrating through data that we're seeing big declines and quantifying that gives you, as you said, firepower to start looking for how we reorganize the healthcare system to deal with so many patients who have needs and deserve surgery, but just don't, we for safety's sake have not transitioned back to the sort of urgent elective or the elective procedures that require help. So I think that's a really, really innovative approach and a thoughtful approach that you've put forward. I do have one question, Francesco, if you could, and you seem like you have quite a bit of insight in this area where other groups are starting to figure this out. In those patients who are coming in COVID positive, with hip fractures, for example. Have you been qualitatively or quantitatively been seeing different outcomes in those patients? I mean, clearly you would have think that hip fracture patients already are at risk and have many, many other risks. But when you add, viral pulmonitis on top of that, how, are outcomes just different now with when in those patients than they might have otherwise been? I assume the case is yes, but I don't have any data to support that.
Yeah, exactly. This is a very good question because this is also an ethical problem because we have an obligation to operate this kind of patient, femoral fracture, within 48 hours in the normal times. Nowadays, most of these patients, with the example of the patient of yesterday, they are all positive for a pulmonitis, and probably the pulmonitis is very clear CT scan signs of the typical signs of a coronavirus. The experience we had so far in the past 4 weeks that this patient, they will not be able to withstand an extended surgery. So also our indication are changing because yesterday we had a fracture of the pelvic fracture. This guy's got 3 months ago a intertrochanteric fracture fixed with a gamma nail, nothing of special. And before again, 2 days ago, he's got a fracture of the lamina quadrilatera with a protrusion of the femoral head inside the pelvis. In the normal times, I would have either fixed a fracture or transformed this fracture in a total joint, removing the gamma nail, bone impaction, cage, and cemented liner. We did nothing. We did nothing because this kind of surgery would have need of some subintensive care unit therapy or period of time, and it's not possible. They're not available because they are all occupied by COVID virus patient. And so we will be facing a change of our indication for this. As a matter of fact, trying to answer your question, yes, these patients are much more at risk of having pulmonary complication after this surgery, because one of the things we have noted that a high percentage of these patients, they do have blood clots much more frequent than a normal patient, because somehow the virus affects also the bloodstream and the coagulation of the blood. And the autopsies done, they have shown that it's a sort of pulmonary vasculitis, moreover than the interstitial pulmonary affection. And so that's again another question, open question: how much of heparin or other preventive medication should be give this patient? For how long? How much before or during or after surgery to prevent deep venous thrombosis, pulmonary embolism? And they die for this. So yes, they are more risk. So that's an ethical issue. Should we operate or not? If we are aggressive, we will probably have an increased number of casualties in this patient. If we are not aggressive, they will not be able to work anymore. So
yeah, it's a very difficult situation, and I think your
experience you will share in terms of data.
No, it's a fascinating analysis of this, and I think it's extremely helpful because we have many surgeons who are now getting into the early waves, of what's going to be happening on the front lines, and your experience is going to be critical. I take it you're taking advantage of this time to be able to collate and hopefully get this information out in the literature. It looks like you're working very hard and writing a lot, so we can't thank you enough from the global community in doing what you're doing. I'll finish up with one final question for you, which is, knowing what you know, being the leader that you have been and having to have gone through something which would be clearly in one of the epicenters of the world, what have you learned from this experience? I mean, what has changed you, possibly for the future, and when you look back and reflect on this time?
again, thank you for your question, because it brings out of me my back thinking during these days, because first of all, we should be prepared to change, as in our life of surgeons. When in surgery we are facing something unexpected, and we should have been trained to solve this problem. Probably we should apply the same rules to our lives nowadays, being convinced that the routine life we have been experiencing so far, successful life of successful surgery, satisfaction with the patient, could suddenly change. So we must be able to confront ourselves with a new reality, and be able to be elastic in our mind, in our heart, to try to find the solution to these new problems. And probably this is a positive aspect of that. We break the routine and we stimulate ourselves to new perspectives. And probably our life will never be the same as before. And probably the life same as before shouldn't be our aim, our target. But new experience brings new knowledge. And probably if I want to see all this tragedy in a positive way, new advantages for us and for the patients.
On that note, Professor Francesco Benazzo, thank you so much for your insight. As I do with everyone at this point, it's routine now to say, please take care, stay healthy, and continue to do what you are doing, because I think leadership is what we need in a time of crisis. And I thank you again for taking these steps to continue to lead in all the work you're doing. So our community is grateful to you, and I'm sure that when they see this insight, you'll get lots and lots of positive feedback. Thank you so much again.
Thank you, Mo. Thank you.